the relaxation of the muscle. The theory behind it basically is to reduce gastric motility, increase the time taken for gastric emptying, and therefore give us time of longer satiety and weight loss. This is the theory behind it. There was the first published article was by Rowling in 2003, and he's only reported one patient who's lost 9 kilos or 30% of the caloric daily intake. Here is our experience, and our experience is mainly as a laparoscopic upper GI surgeon. I do a lot of bariatric surgeries in terms of surgical intervention, and over the years we've developed expertise to be a bariatric endoscopist as well. So in my department we do almost all sorts of endoscopic procedures used for weight loss. So with the endoscopic gastric botox, our experience in terms of data collection started in December 2012. And we've studied our patients with a 6-monthly follow-up. Therefore, the patients followed up in September 2015 were actually done in March 2015. The total number of cases in our study period is 185 cases, with 32 people or 32 patients who have lost to follow-up, simply because we get a lot of patients from the countries around us, a lot of patients from Qatar, Saudi, Kuwait. The local patients we managed to get hold of and follow up closely. Therefore, the total cases studies with a 6-monthly follow-up is 153, and you can see there are more females than males, and the wide range of age group between 15 to 51. Here is the trick. All patients were seen by the dietitian prior to the procedure and were followed up as a combined team. 300 units of botox was injected in the fundus, body, and pylorus. Now, this is going to be something different if we get to publish any of these results, because many of the published data reports injecting botox into the antrum. We have, and again, this is all theoretical, and this is just an observation of our department. By no means this is research, but we will research it in the future. Our observation is, if you inject the fundus with botox, the observation is of loss of appetite or increased satiety. Injecting botox in the body of the stomach gives you reduced speed of gastric emptying or reduced speed of gastric motility. With injecting botox in the pylorus, however, and this is again, you might argue, if you relax the pyloric sphincter, you're going to empty faster. In our experience, it's the other way around. When we relax the pyloric sphincter, there is a delay in emptying the stomach of especially highly fibrous food material. So this way, we notice that our patients have actually longer satiety, and this is how they lose weight. And I will share with you some of our results. The other thing we do is, again, a strict diet protocol of lactose-free and gluten-free is applied on all of our patients, and our dietitian will give you an idea about this at the end of the presentation. Here is our criteria of selection. We really select our patients very, very carefully. This is not done on anyone who comes through the door of the clinic asking for the procedure. We select them very carefully. We select the educated, sensible, compliant patients who have realistic expectations of the procedure. Those patients who have failed to lose weight with diet and exercise programs. So this is not offered to anyone who's lazy and just wants an easy way out. They've got to prove to us they've tried diet and exercise, and if they haven't, they see our dietitian, and then again, she'll give you more details about that. Our age group, we declined children below the age of 15 or elderly above the age of 60. No scientific reason. This is just a hit of a stone. BMI of between 27 and 40. Diabetics on medications were excluded. However, we did not decline diabetics on diet control. Patients with multiple diseases or metabolic syndrome were also excluded. Very quickly, just the results. Again, you can see this is just an observation. This data is, I have no control group. This is not a data of research material. This is just the observation from my department or my clinic. We've divided the groups of our patients into body mass index. Body mass indices between 27 to 29, the lower BMIs, and we have 22 patients. BMIs between 29 to 32, we had 31 patients. Heavier BMIs of 32 to 36, we had 66 patients, and between 36 to 39, there were 34 patients. Now look at this. When we started this procedure, we were thinking, let's limit this procedure to the lower BMI, because this is not suitable for a higher BMI. But after we have our observation over the 3-year period, we've just proven ourselves wrong. This works better for heavier patients. You can see here, in the lower body mass indices, 27 to 29, 5 patients out of the 22 patients did not lose any weight. 0 weight loss, 5 patients. And the maximum weight loss there was 9 kilos. The second group there, BMI of 29 to 32, 3 patients out of 31 patients have not lost weight, 0 weight loss, and a maximum weight loss of 10 kilos in 6 months. Now you might argue that they do better with a dietitian than they do with me. Well, you're quite right. And we offer this just for the patients who have failed to lose weight with other means. Look at this, the third group here, the BMI between 32 to 36. We've got a minimum weight loss of 9 kilos over 6 months and maximum of 18 kilos. 2 patients actually lost 18 kilos. And 8 of them were diet-controlled diabetics. And we've noticed a huge difference and a great improvement in the HbA1c after the 6 months follow-up. The last group there, well, you might argue again, these are the morbidly obese. Why are you doing this procedure on them? Well, we'll talk about the criteria later. But out of the 34 patients, I've got one of the 34 who have lost 23 kilograms. Now that's 8 points reduction in the body mass index, 8-point reduction with a non-surgical intervention. 13 of them were diet-controlled diabetics, and they've lost an average of 16 kilos, again with an improvement of HbA1c. So between December 2012 and March 2015, and I'm talking about the 6-monthly follow-up of the 153 patients, only 46 out of 100 continued follow-up after 6 months, and these were all of the higher BMIs between 32 to 39. The lower BMIs have just vanished after the 6 months. Those who have followed up with us for more than 6 months, they've maintained the weight loss with plus or minus 5 kilograms. We have no accurate follow-up on 77 patients, which were followed up until March 2015. However, we tend to kind of in a friendly way contact our patients by text and phone calls, especially those who refuse to come to clinic. And we realize that just by general conversation with our patients, that most of them have regained some or all of the weight that they have lost. So this is telling you something. Follow up your patients. This is not a procedure that you can market for or use commercially. Bring the patients on, do your endoscopic botox and let them go. That's going to be a failure of a procedure. I think in our opinion, follow-up by us and a dietitian, a strict follow-up is very, very important. It's much easier for me to follow up a patient after a sleeve gastrectomy or an omega loop bypass because we know they're going to lose weight on a protocol. With the botox patients, we really need to keep an eye on them. You see here, 77 have vanished out of the 153 patients whom we followed up for 6 months. 12 patients have requested to repeat procedure for different reasons. Some of them liked it so much and they wanted to maintain. After the year, they came and requested to repeat the procedure. And some of them actually who were non-compliant to start with, especially those who didn't lose any weight, came requesting repeat procedure. So the 8 patients are talked about in the results who have lost no weight at all were all in the adolescent group, aged between 15 to 21. Again, that's telling us something. When we're having guidelines or protocol for this, should we exclude the adolescents? As I said, we have a good experience with the intragastric balloons and the O-balloon balloon capsule, the pose procedure, the endoscopic endo barrier, and we found that the endoscopic gastric botox have very comparable results. The results are very comparable, maybe slightly better. Is it because this is a new procedure and we're following up our patients better? And with the balloons, we're not following as much? I'm not sure, but the results are slightly better than other procedures. It's safe. We have no reported complications. However, 20% of our patients complained of constipation, which was sorted out with laxatives. In terms of expense, I think, again, the expense is comparable with the other procedures, maybe a little bit more cost effective for the amount of weight loss that they have. Is it temporary? Yes, it is temporary, as for every other endoscopic procedure that we do for this, for the obesity problem. Metabolic benefits were not studied in detail. However, in general, improvement in insulin resistance and HbA1c was noticed. This is not because of the gastric botox, this is because of weight loss. So I think I attribute this to the dietitian more than to myself. Again, we have to be careful with this. Lately, especially this beginning of this year, people and clinics were marketing for this procedure, and this was becoming very commercial. Endoscopic gastric botox, replacement for surgery. No, you don't need surgery anymore. This is the golden procedure. Well, guys, it's not. Okay, it is not a replacement for surgery. This is a temporary procedure. It's to lose you between 20 to 30% of your weight, and this is where we should stop. So we should have endoscopic gastric botox as an option for some suitable patients, rather than market for it commercially and say this is the golden procedure. It is an option for the high-risk patients or those who refuse surgery. Now, most patients claim that endoscopic gastric botox helped them to comply with the strict diet protocol. Without it, we couldn't have done it, doctor. The botox had helped us to continue with our diet. Therefore, our impression is that the weight loss that the patient experienced was basically due to the possibility of compliance with the diet protocol, rather than a magic procedure which is doing something that is coming from the extraterrestrial world, yeah? So our recommendations is that please actively involve the dietitian from the very beginning. You need a dietitian who understands what you're doing, who understands what you want, who can simply apply your request of the lactose-free and the gluten-free. Be honest with your patients, be very transparent with your patients, and have a special consent form. Because this is, in a way, a new procedure. It's been there since the past 10 years, but still considered to be new. In Dubai, we're one of only 2 or 3 clinics who does it. The other clinics, as I know, the numbers are much lower than ours, so therefore we can come and talk with an observation of over 100 patients. Carefully select your patients, please. Select the compliant, educated ones, the well-informed patients, sensible. Avoid high expectation patients. We are here in the Gulf. Get used to it. People will come and say, doctor, my friend is getting married next week. I need to lose 20 kilos. All right? This expectation is not possible. So avoid this procedure in these patients, please. All patients, as I said, with zero weight loss were in the adolescent group. And the last thing I would like to say is we need more studies, proper studies with a control group, with a longer period of study and more sample number. This for us is a start of research, and we will do it, and we're hoping to present in Rio de Janeiro in the EFSO conference next year, hopefully. And I hope we have accurate results. So please do remember, my slides today are all observational. By no means this is research. This is just one department's observation. Some references for you, please do have a look. And the very last word is the role of the dietitian. The dietitian is an active member of the team. Please join me, dietitian, Dr. Suhad. And patients counseling and education, the dietitian helps me a lot to do this. Preparation for the weight loss mission, to give them the boost, the jump start that they need. You need a dietitian to do that. We are very busy in a surgical clinic. Doctor, you're a surgeon, and you know how it is in the clinics. We're very quick, and you get 10-15 minutes to see your patients. You do need backup, and the dietitian is my backup here. So please do give her a couple of minutes and let her tell you what she does with these patients. Dr. Suhad.
Please, 4 minutes, please.
Yeah. Good morning. I just divide the consultation or the lifestyle modification which coming along with the AGB. I divide them for like 4 stages. The first stage is the consultation day. You might be in this stage if you have been considering change but you are not ready to start. You believe that your health, energy level, or overall well-being will improve if you develop new habits. You are not sure how you will overcome the roadblocks that stand in the way of success. You just need a push. Stage number 2, preparation day. 2 or 3 weeks before the procedure, you are making plans and figuring out specific ideas for the weight loss that will work for you. Most of them end with failures. You have set some specific goals that you would like to meet. The stage number 3, procedure day. After EGP, you are enacting on your plan, and as I am a dietitian, I am making the changes which will help you to achieve your target weight. You are adjusting to how it feels to eat differently or be more active. You have been troubleshooting to overcome things that have blocked your success before. Stage number 4, the maintenance. I have a new routine 3 to 8 months after the EGP. After celebration the weight loss results, you have become used to your change and have kept it up for more than 6 to 8 months. Follow up with the dietitian will make sure that you are in this stage if your change has become a habit. And this is the main role. We are helping the people. Dr. Enas, she's giving the push, or all the other surgeons, they are giving the push, but now it's the patient role who they have to keep this change as a habit. You have found creative ways to keep going and stick with your routine. At the end, this is a patient feedback. Without AGB, I couldn't reach my target weight, where there is no hunger and there is no suffering. Thank you.
Thank you, Dr. Al Alawi and Dr. Safat, for a beautiful combined talk on the botox. Any questions from the...
Dr. Bismar from Riyadh, Saudi Arabia, General Surgeon. Thank you, Dr. Enas, for your very nice temporary procedure for weight reduction. First of all, I would like to admire your care of taking and showing your assistant. Then I have two questions quickly. If somebody asking for doing laparoscopic surgery for weight reduction, like sleeve, or do you do such procedure for him as temporary, or you let him go immediately to surgery? Second question, that injection the botox in the fundus of the stomach does affect the gastroesophageal junction. Does the patient complain of nausea, vomiting, and reflux esophagitis?
In terms of surgery, doctor, we work our patients and we have a very strict criteria for surgery. When they qualify for surgery, they qualify for surgery. We don't do any middle procedures. Some patients who are not sure and they come and ask for this procedure when their BMI of 50 and 55, we decline, because if you're 50 kilos overweight and I lose you 10 kilos, what have we done? You're still obese. So I wouldn't do this procedure on the heavily on a BMI of more than 39. Once they qualify for surgery, they go for surgery. In terms of, you asked me about nausea and vomiting, very minimal, very minimal. We don't have that as a problem. And this is what I tell my patients. If you're within my criteria, the selection criteria that I have, but I still don't think that your lifestyle and habits would comply with this procedure. And if you force me to do it, I might do it, because it's a complication-free procedure. If you ask me to do a balloon and I'm not convinced, I'm not doing it, because I know what's going to happen with the balloon. So this procedure, in our opinion, really is very minimal complications. Patients come an hour before endoscopy. It takes 5 minutes to do the procedure under sedation. They go to the room within half an hour. They start drinking their juice and soup, and they're home. So it's a total of 3 hours in hospital from arrival to departure. It's a quick procedure. Not at all. Not in the 185 that we have followed up.
Yeah, very nice presentation.
Thank you.
Regarding have you come across any acute dilatation of the stomach following the...
Acute dilatation.
of stomach, because the injection will botulinum will paralyze the stomach. You come
Yes.
across the gastric varices.
Yes, you're right, doctor. We actually give them very strict diet protocol of liquid, only clear liquids for 10 days. Clear liquids. And this is again talking about the pyloric sphincter. When you relax it, fluids will pass easily. You know, you drink your fluids and you go for a walk with gravity, it will pass. But if you eat, it's not going to pass. And we assess our patients emotionally, psychologically, and make sure they will comply. Those non-compliant patients, if they go and eat after injecting high-dose botox in the stomach, I think we're going to have problems. But so far, because we're very, very highly selective of our patients, we don't have problems, and we're kind of happy with the weight loss. But I don't want to give an idea that this is the golden procedure.
Thank you.
Yeah.
Thank you very much for your nice presentation. You mentioned that this is an observational experimental that you have done. If you want to do it as a case control in future, I wonder what are your thoughts if you wanted to progress in this research. Thank you.
Yeah, well, I think, again, we're lucky and blessed to have a dietitian who knows exactly what we're doing. So if I do this in a proper research model, I would have a control group. And it's very easy for me to have it because I've got a dietitian with a high volume, very busy clinic. So she can give me the control group. And we can just have fix the parameters and have a control group and have the Botox group and see what happens. But you do need a longer follow-up period. I don't think 6 months is enough. However, in our opinion, that within 6 months, the Botox would have reabsorbed or absorbed completely from the stomach. So the motility is going to be back to normal. And this is why we've picked a 6-month follow-up period. But I honestly believe if we can do a 2-yearly follow-up period with a control group from the dietitian, is going to be better, more accurate results.
Thank you. And I suppose last question.
Thank you for this presentation. My question is, you are against doing this procedure to patients who have very high BMI, for example, like 50 kg above. But sometimes before doing the sleeve or gastric bypass for super morbid patients, we prefer them to lose some weight before doing the procedure, just to prevent the thrombosis, PE, and other complications. So I think this procedure is like a good tool just to help patients to lose weight before going to the definitive final procedure.
Yes, I agree with you. Yes, you can use it. And did we use the balloon or the pose and the endo barrier and all these procedures as a primary procedure to the high-risk morbidly obese? Yes, this is applicable. However, I don't have data on the superly or the morbid obese. How much is this going to help you? Probably a balloon is going to be more helpful, but this is just a guess and a theory. Because, again, another study we've done a few years back, we've done barium meals on all of our pre-op patients, and we've divided them into different BMI groups. And we found that the higher the BMI, the bigger the stomach. So, with these BMIs of 55 and 60, how much Botox are you going to inject? And this is just a question in my mind. If you're using the O balloon, for example, you're probably going to need to put 5 or 6 of them. If you're using the adjustable balloon, you're going to have to go a maximum size. So, with these patients and the Botox, I'm really not sure.
Because according to your study, patients who had higher BMI lost more weight than patients who
That's
had
right.
less
Again, remember,
BMI.
these are all below 40. BMI is below, the maximum BMI we have is
Won't be
39.
applicable for patients who have higher BMI, because really it's like a good tool to ask patients to lose their weight, because some patients are not compliant and won't be losing weight because they're lazy patients. So if you use this procedure just prior to the definitive final procedure, it will be like a great help, and decrease the complication rate.
Yes, I wish we can actually continue and do a bit of research on the higher BMIs. We'll try that. As I said, I started this and I was absolutely not convinced that I should do this procedure on a BMI of higher than 33. And I used to be interviewed and by the newspapers and the TV and whatever, and I used to say BMI between 28 and 33. Anything above that, this procedure is not suitable. I've said it myself, and now I've proven myself wrong. So it works better between the BMI of 32 to 39. And I think we need to take this further. It's an excellent procedure, complication-free. In terms of cost, is very reasonable. I think we should take it further. And inshallah we will, yes, hopefully.
How
Thank you.
often do you inject these patients?
How often? Well, we try to do it once and for all, but some people come in and ask to repeat. we don't like to repeat it. We like to do it once and for all.
Thank you.
Well, if these patients have tried Botox cosmetically, I would ask them, how long does it take before you need a re-injection? And those who tell me 1 year, I'm reassured. And those who tell me, doctor, I repeat my Botox every 6 weeks, we've got a problem. So is there a problem with using too much Botox? How much Botox do you use? You know, all these questions, I don't have data. There are no guidelines. I'm doing this like throwing a needle in the ocean. So we're just guessing it at the moment until we have proper guidelines. Give me 3 years.
Thank you
We'll
so
give
much.
you 3 years more.
3 years, please.
Okay, thank you very much.
Thank you.